Good afternoon, everyone. So we just had a presentation from Dr. Saif, and it was fantastic. So we thank Dr. Saif for that. We are going to, at Black Health Matters, continue talking to the African American community about HATTR amyloidosis. We are going to be having some forums from September through December of this year. If you have interest in helping us host a forum, please share that information with our representatives in the exhibit area at the Black Health Matters booth. Great. So now I want to talk with you about endometrial cancer. And this session, we have partnered with ASI to produce this content that is, we feel, really impactful for African American women. So in terms of endometrial cancer, it's one of those cancers where people can survive. The rates are pretty good. It's just getting diagnosed. Unfortunately, from what I understand, African American women normalize heavy bleeding and really don't think about it in terms of like, let me run and get help. They kind of just take it on the chin and keep it moving instead of asking questions. And that's what I'm hearing from a lot of patient testimonials. So let's just get some stats about endometrial cancer. African American women have a higher incidence of more aggressive types of endometrial cancer than general market women. Young African American women are more likely to present with pathologically aggressive advanced stage tumors. So that's also something to think about. While the stats may be startling, we have a patient expert with us today and a leading physician to speak about endometrial cancer. So let me introduce my esteemed panel. We have Dr. Mitzie-Ann Davis, a Piedmont Physicians, Fayetteville Gynecologic Oncology. Dr. Davis earned her medical degree from Temple University School of Medicine in Philadelphia. We have a patient advocate, Jurline Redeaux. Jurline, you'll have to help me pronounce your last name. And she's our patient advocate who holds, thanks, who holds a master's in social work from the University of Southern California. She founded her own nonprofit, which is called New Impressions, which is a 501c3. Yeah. So together, they're going to talk with us about.
Thank you so much.
Thank you so much for inviting me. Good afternoon, everyone. My name is, thank you so much, Rosalind, for that wonderful introduction. So my name is Dr. Mitzie-Ann Davis. I'm a gynecologic oncologist down in Fayetteville, Georgia, which is about 30 minutes outside of the city of Atlanta. And today I wanted to take some time to talk about endometrial cancer. As Rosalind said, a lot of Black women tend to think postmenopausal bleeding or heavy bleeding is normal, and it's not. And at the end of my talk, if you don't hear anything else, I want you to hear that that is abnormal and you need to seek medical evaluation. So what Black women need to know. So first of all, the endometrium is I don't know if you can see my cursor. The endometrium is the lining of the uterus. So that's what we call an endometrial cancer, which is separate from a cancer just of the muscle of the uterus. Endometrial cancer is the most common GYN cancer that we see. And the reason is the risk factors and I'll talk about that. Being a woman, being over 55, being obese. Those are the three top ones. Even though it's the most common GYN cancer, if you're gonna get a GYN cancer, this is the one to get because it's easily treatable with a hysterectomy. And typically, if you recognize that these things are abnormal, we catch it early and it typically is a stage 1 and over 94% of patients will go on and will survive 5 years down the line, okay? The issue is people either ignore these symptoms or they talk to their friends and say, oh, I had that, that's normal. And they wait and they have delayed care. And by the time we find it, it's more advanced, more aggressive, and it's just more difficult to treat a stage 3 or 4 disease rather than a stage 1 or 2. So I'm gonna be talking about the risk factors, symptoms, treatment options, survivorship, and we're gonna be talking to Ms. Jurline Redeaux, and we're going to make sure we hear her side and see, you know, I, as a physician, when I speak to patients, I know sometimes it's interpreted differently. So it's really good to hear her experience and the things that we can improve as physicians to make that process seamless for patients. So endometrial cancer, as Ms. Rosalind had shared, is the most common GYN cancer. The incidence continues to go up. For this year, new cases will exceed 65,000, and the death rate of the number of deaths will exceed 12,500. Here's a picture of what it looks like when I do a hysterectomy and I remove it. Here's the uterus, here is the tumor, and then here's the cervix and the fallopian tubes and ovaries, and that's where that tumor is. Risk factors, okay, include obesity, #1 risk factor. Normal BMI is 26. 5 BMI units over that increases your risk of developing endometrial cancer by 50%. Age is another thing. Family history. So if you have a very strong family history of colon cancer, endometrial cancer, ovarian cancer, you might have something called Lynch syndrome. You need to get tested. You need to go talk to your GYN so they can send to genetic counselor so that we can do risk reducing, hysterectomies, removing the uterus. Drugs as well, for patients who have had a history of breast cancer. Sometimes they put you on a drug called tamoxifen that helps to regulate that breast cancer. But the other side effect of tamoxifen is that sometimes it can stimulate the lining of the uterus that can lead to endometrial cancer, and also prior radiation. So there are 2 types of endometrial cancers. There is what I call the run-of-the-mill endometrial cancer type 1, endometrioid, and this is typically caused by an overstimulation of estrogen. So when you have excess adipose tissue or fat cells convert to estrogen, and that estrogen can cause the lining of the uterus to increase and lead to a cancer. Those are the ones that are easily treatable with hysterectomies. Most patients go on and they're fine. However, you have a type 2, and these type 2s are more aggressive and more difficult to treat. These are called clear cell carcinomas, papillary serous cancers, and also carcinosarcoma. And unfortunately, Black women tend to have a higher incidence of these more aggressive cancers, and for reasons that we still don't quite understand. So the symptoms of endometrial cancer. So this is the 3rd time I'm mentioning it since I've been on this talk for 5 minutes. Postmenopausal bleeding. For some people, that might look like a period. That might be heavier than a period, passing large clots. That may be abnormal brownish discharge, totally abnormal. For some people, it might be clear discharge. Sometimes you might have bleeding in between periods. If you're still young, because we're seeing younger patients with endometrial cancer, and the risk factor there is obesity. Heavy vaginal bleeding, bleeding after sex. And sometimes we have an incidental finding that they might not have vaginal bleeding, but somebody did an ultrasound for whatever reason, and it was a thickened, the lining, the normal lining is 4 millimeters. And if it's higher than that, typically we tend to make sure that there's nothing more serious going on. This can be easily diagnosed by an office procedure called an EMB, endometrial biopsy. It looks like a straw. It's like a pelvic exam. It hurts for the first maybe like one minute, like a big strong cramp, and then it goes away. You might have some like dull pain for like 30 minutes, but it easily is tolerable. And if we don't think that you can tolerate that in the office, or if the cervix has closed and it would be very uncomfortable to try and open that cervix in the office, then we also can take you to the OR, which is a same-day procedure. We put you to sleep, give you some IV sedation, and we do a scraping, a more aggressive scraping of the uterus. The treatment, as I said, is a hysterectomy. And a hysterectomy typically means removal of the uterus. Removing the tubes and ovaries is called a bilateral salpingectomy, bilateral salpingo-oophorectomy. And some people tend to say, I had a partial hysterectomy. And sometimes patients themselves don't even understand what that means, because I'll go in and everything is still there, or partial and everything is gone. So I always try and tell patients, hysterectomy really means removal of the uterus. Salpingo-oophorectomy means removal of tubes and ovaries, okay? And sometimes, occasionally, and here's a picture of, let me go back. So here's a picture of what it looks like in the uterus when I do like laparoscopy. Here's the uterus, here's the ovary, here's the fallopian tube. This is the bowel and the rectum, and this is the cervix down here, okay? And so when we do a hysterectomy for endometrial cancer, we remove all the GYN organs and close that at the top of the vagina. Sometimes we may have to sample the lymph nodes in the pelvis and along the aorta. We have something called sentinel lymph nodes now that we can do a sampling instead of removing the entire lymph node package. And what that does is really decrease the risk of having lymphedema. That's that swelling in the lower leg that really can impact quality of life. Sometimes some patients may need radiation and chemotherapy after treatment. Sometimes it's so far gone that they're not candidates for surgery and may need to start with chemotherapy and radiation upfront. In terms of the surgery, there are 3 different ways that we can do surgery in this day and age. We can do a traditional midline laparotomy. Okay, that incision takes a long time to heal, have increased risk of complication, wound infection. It takes longer, you have to stay in the hospital for a couple of days. And then we had traditional laparoscopy, which is where you have small incisions, you have a straight stick laparoscopy, less time for healing, patients did well. And then we've had the Da Vinci robotic system from about 2007. And this is a more advanced laparoscopy. And patients have even less pain because you don't have as much disturbance of the tissue. And really and truly, minimal invasive surgery is standard of care for endometrial cancer. If no one is offering that to you, I strongly suggest that you seek a second opinion, okay? Very rarely do I have to do a laparotomy, that is that midline incision for endometrial cancer, unless the uterus is very, very large, or if I feel that they have disseminated, widely metastatic disease that I feel that I can remove at the time of surgery and I need to do a big traditional laparotomy. And that's me with the robotic system. That's how we drape it. And that's me working at it. And that's what it looks like when it comes out. There's the uterus.
Oh my gosh.
Yeah, the ovary, fallopian tube, and cervix. And this is what it looks like for the patient. So I did all of that and do lymph nodes and everything. And they have all these small, teeny incisions. Best thing, they go home the same day. My oldest patients do this surgery 92, and they did great. And they were having tea with their friends within a week. So this is, you know, the advantage of using a surgery like this. Chemotherapy, as I said, sometimes you may have to do that. Typically for most GYN cancers, standard of care and first line is carboplatin and paclitaxel. And some of the side effects include losing your hair, neuropathy, that's burning in the hands and feet, fatigue, bone marrow suppression, and as I said, nausea and vomiting. In the recurrent setting, we're still working on what is standard of care, which we still really don't have any really good treatment for second line. But one thing that is emerging is immunotherapy, something called Keytruda. So using your immune system to help to fight this. And we have a lot of patients, if they have a genetic defect that we can exploit, like a PD-L1 in their tumor, that they do really well with this drug. Of course, molecular profiling. So what does that mean? When I remove the tumor, especially for patients that have advanced or more aggressive tumors or recurrent, I typically send it to see if there's any specific genetic defect that I can target. So we're target meaning if there are any other treatments that can really exploit those. And of course, clinical trials. Dr. Brown of Sloan Kettering is going to be talking about that later. I wanted to highlight that because traditionally we have been underrepresented in clinical trials. And it's really important that if you are a candidate or if you're eligible, that you strongly consider a clinical trial. And a clinical trial typically happens, you know, for patients who have either rare cancers, or if they've failed other types of treatment, that we're trying to explore and see which treatments work. And sometimes they work, sometimes they don't, but we don't know until we explore these options. And of course, hair will always grow back. And I kept my hair low for such a long time, really camaraderie with my patients. And I was like, it's just the least of your troubles right now, and, patients, typically are up for the fight when they come, the first time, and they're like, I want to do whatever I want to do to stay alive. So where specifically I wanted to spend some time to talk about endometrial cancer and Black women. And as Rosalind had said, we have poor outcomes. So this information, we've had like several studies, retrospective studies from the SER database. SER database is a cancer registry that kind of tells you all the information about patients that have been diagnosed with any type of cancer, their age, their socioeconomic background, their payer status, if they had insurance, didn't have insurance. And a lot of times we can query this database to see, what information can we have. And disturbingly, we have found that Black women will have less survival than our white counterparts for endometrial cancer. We are more likely to be diagnosed with an advanced stage or a more aggressive type of tumor. To me, as a minimally invasive surgeon, the biggest one that I always try and tell my patients, if no one is offering you minimal invasive surgery for endometrial cancer, you need to find a second opinion, because we're less likely to be offered minimally invasive surgery. And also, and even surgery on a whole, we're twice as likely to not be recommended surgery. And white women are more likely to receive vaginal brachytherapy and external beam radiotherapy, which is another type of treatment that we use after, than our Black counterparts. So there is clearly a disparity, okay? Yes. For some reasons we don't understand. No, we know the usual, right? Systemic racism, socioeconomic background, regional, payer status, all those different things. But sometimes we don't really quite understand the nuances as to why we're still seeing this. And one of the first studies that came out with this health disparities in endometrial cancer came out in the 1990s. And they're still writing papers and nothing has changed. That's the saddest part, that this is still persistent and we're still publishing about, yes, this is what's happening. No, we really need to move that to how can we equalize? How can we improve equality, health equality, so everybody can get the same care? Chemotherapy, as I spoke about, some of the lasting effects, you might have radiation, vaginal dryness, sexual health. That's so important. Sometimes we don't get to talk about that, because if you have, changes after you've had a hysterectomy, changes after you've had radiation, the tissue can get very dry, even from removing the ovaries. You no longer have any hormones, natural hormones. And so these things are very important. I really encourage you to talk to your provider to make sure that all your issues, all your concerns are being addressed. It's not just about the cancer, we did surgery, you continue to survive. And with survivorship comes with all the different things. You might start to have, side effects from the radiation that you did, that you didn't feel for the first 2 years, but now it's starting to affect your bowel, or it's starting to affect your bladder, and you're starting to have bleeding and different things like that. We also like to coordinate with the PCP, or primary care provider, medical oncologist, radiation oncologist, GYN oncologist, so that, all those different things are being addressed. Some people might have side effects from the chemotherapy we give them that can affect their heart or other things, or the neuropathy. Sometimes that neuropathy is lasting. So we definitely want to make sure that we're having a more comprehensive approach, so that all these different things are being addressed. And in terms of surveillance, once you've been diagnosed with a GYN cancer, we typically want to follow you closely. Any GYN cancer tends to recur within the first 2 years. And so we watch you closer every 3 years for the first, every 3 months for the first 2 years. And then after that, we stretch it out to every 6 months. And then when you get to 5 years, they would just see you annually. We don't normally do CT scans every single time unless there's an indication. We're really trying to come back from doing these unnecessary CT scans. And pap smear is another question I always get. I just had a normal pap smear. How comes I didn't find it? Well, pap smears are only for cervical cancer, picking up abnormal cervical cells. It's not to evaluate what's going on with the ovaries or the tubes or the endometrium, okay? And survivorship I spoke about. Surviving cancer, I always want to tell my patients, is not the end of a gruesome story. It's the beginning of a beautiful one, okay? You survive. My job is to let this be but just a memory in your head, and you go on for the rest of your life. And hopefully that you can take this information to educate other people, okay? And here I have always like to include different trivia, but this is Gwen Effel, who died from endometrial cancer in 2016. Again, she had a more aggressive type, and typically when we find it, it's more advanced. So again, postmenopausal bleeding is abnormal, okay? If you are having any abnormal vaginal discharge, anything like that, I really want you to seek medical attention. Endometrial biopsy, very, very easy, can be done in the office. You get the results in 5 to 7 business days. And from that, they can refer you to a GYN oncologist, okay? Because as a GYN oncologist, we only do cancers of the reproductive tract. And it's good because if there needs to be lymph node dissection needs to be done, we can do everything at the same time rather than subjecting yourself to 2 separate surgeries or to not be completely staged. So I want to talk a little bit about patient experience. So, you know, this is my experience as a physician, all the information I can give you. But I know that when I give you all this information, most of the times it goes through one ear and comes out the next. And all they want to know is that, am I going to be alive? Am I going to die today? You're not going to die. This is an easily treatable GYN cancer. And so I want Miss Jurline Redeaux to, you know, tell us about her experience. Miss Redeaux, how did you feel? What were your symptoms first?
Well, thank you so much, Dr. Davis. First of all, I am hypervigilant about my health. And that's the one thing I want to put out there is going to be, you know yourself better than anybody else. My first symptoms occurred as a dot. I was post-menopausal. I want to let everybody who's listening, it might not even be a heavy bleed. In my case, the year was 2016, and I saw a small dot when I went to the ladies' room. The next day, it was a little bit heavier. I immediately, self-advocacy is what you're gonna hear from me. I immediately said, I went to the car, called my doctor's office and said, you know what? I need to get in there now. She said, well, your primary care doctor is out. It was Christmas. I said, well, then I need to see anybody who's there. If I can't get any other message across, and I know we don't have much time, is that you're gonna have to be your self-advocate.
Yeah.
Dr. Davis is giving you what you need to do, but you're gonna have to be the one that's gonna take it to the next level. And that's why I'm happy I partnered with Ecana, Dr. Kimmy Dahl, who was so concerned about the stats that Dr. Davis told you about, that she made us ambassadors. So I'm also an Ecana ambassador. Getting back to that, I got into the doctor's office on a Friday. Listen, Wednesday, Thursday, Friday, I'm in the doctor's office. Immediately, I'm already been to Dr. Google. Dr. Google says 2 things, endometrial cancer or something about my uterus was something getting old or, you know, the word I don't know. But anywho, I was definitely postmenopausal, ladies. You should not see anything after your last period like the doctor told you. Nothing. Do not chalk it up to you move some furniture. Do not chalk it up to I'm stressing. Get to the doctor. Don't let anybody tell you no. Had I not did that, you would not be talking to me right now. That is what saved my life. You're right. I did have the initial pap smear. I went on a Friday. It was Christmas coming up. January 2017, I finally got in to have the biopsy. Dr. Davis, honey child, that thing hurt. You're talking about a cramp. Look, I thought I was going to pass out. So Jurline is back. I was diagnosed with endometrial cancer 2017, but I want to see the window. I want you guys to see how quickly I got to the doctor's office. Across the board, we've already talked about this. Our risk factors are the same, but what we're not doing, we're not following through. My experience has already been discussed. My doctor turned around in his chair when he saw me for the first time. He spun around in the chair. He looked me in my face and said, Jurline, you saved your life. From that point on, we were going through the same. I had the robotic. Once again, you guys, if I hadn't got there so soon, I wouldn't have the robotic. I ended up having chemotherapy because I had stage 3. Did you take anyway? Please take away what I just said. Went right away, stage 3. That is the, if we don't get anything else, I want, and I know our time is short, I want to get the most important thing out is that you got to get to the doctor with any abnormal bleeding, young ladies especially. And if you don't have an advocate, thank goodness there's organizations like Icana, Sierra Sisters, which I partner with them up in Seattle, New Impression down here in Los Angeles. I'll go with you. Advocacy is important because you can't hear. What Dr. Davis said, you cannot hear. You can't process it. Another thing that was fortunate for me, I'm already been on that vital field, as they say, for the Lord. I've already been talking about healthcare disparity. So when it came down my street, I knew it was time for me to be very proactive. Family history, yes, my mother had breast cancer. No, she didn't die from it. She died from diabetes. Another thing I want to tell ladies who are pre-diabetic, do not take it lightly. Have your doctor monitor and run tests. And I know I'm running out of time. Just because we're over the age of 60 does not mean we don't still use, we need to see the gynecologist. That's another point I want to make. If they tell you a pap smear didn't show nothing, she gave me a pap smear. Guess what? It was clear. I was stage 3 when she gave me that pap smear. Do insist on seeing the gynecologist, no matter what they say. And the last thing that I always say, change your medical provider. You can look on the back of the card when I do these presentations in person. I say, you see this little card? Turn it over. Call somebody. You don't have to stay with that provider. I want to empower you. If I can't do nothing else in the minutes that I have left, is I want to empower you to take back control of your health. Not only with this, everything, obesity, take it back. Take your control back and have some conversations with your doctor. And my experience, I was fortunate. I was part of the team. You are driving that team. If you don't feel like you're driving it, then you need to have another conversation. Because the most important thing, like Dr. Davis, she's trained to do what she does. But if you walk in there and you say, I want a team, I want to know what I need to do next, I want to know how to be healthy. And let's talk about hair. Before we can complete this discussion, hair does grow back. But see, I didn't have that problem. I had alopecia already. So you know what? I had one thing I didn't have to worry about coming in the gate. Don't worry about your hair. Don't worry about your appearances. All that stuff can come back, but we can't come back from the grave. So what I want to say to you ladies today, take away from me a patient that had a good experience because she went early. I have also interacted with other women in the past 3 years. I am now into my 2nd year. I see the doctor Monday. He's going to be very proud that I participated in this because he considered me, he heard me. You got to be with someone who is definitely hearing you. So I just want to complete, I only have a minute, but what I do want to say to you guys is all of the things that you heard, we now have websites, we have Black Health Matters, we have so much more than our parents had. And let me just say, you've been hearing a lot of things in a conference, kind of like, oh my God, we're Black women. But I just want you guys to take a good look at me. I am 69 years old. And when I tell people I have cancer, they looked at me like, are you kidding me right now? I am what survivorship looked like. So when you go in the doctor's office, if you can't put a pin on nobody else's face, put a pin on mine. So thank you guys so much. I'm honored to share that it's not all gonna be easy. Yes, I have neuropathy, I do, but once again, I get to see my doctor more. And it's really helpful for COVID-19 because now I get to see my doctor on Monday. Thank you so much. Thank you, Rosalind. Thank you for inviting New Impression to the table. This has been a collaboration to me as well as a summit. a virtual summit.
Well said, Ms. Jurline. Thank you so much. It's an honor to share the stage with you.
Thank you. Thank you.
We are gonna go to questions now. Can you hear? Is Rosalind there?
Rosalind is moderating our questions.
No time.
Okay, no time. So we got to end it. So I guess we can probably get back to our questions via chatting or getting, Dr. Davis, you and I will work out the questions together.
Okay, not a problem. Okay. All right, thank you so much.
Thank you, everybody.